you can feel, you can hear me. I have a little bit problem with my voice. I hope you can feel me here. So I would like to thank the organizers very much for inviting me here today, and it's really great to see all of you here. Very exciting. And I would like to share with you today our trance methodology, in which we apply MRI for differentiating tumor for treatment effects in brain tumor patients. I'm representing a large collaboration that started here at Sheba with different disciplines, and then it spread throughout Israel. Today we have several international collaborations, and these are my disclosures. I would like to emphasize that we licensed this technology to BrainLab, and it is CA and FDA approved. I would like again to apologize for my voice. I really hope you can hear me. I know it is annoying. Hopefully it will come back soon. So how do we differentiate tumor from treatment effects? We scan our patients with standard T1 weighted MRI a few minutes after contrast injection. We do a standard brain protocol, and then we take them out of the machine and we bring them back for another 3D T1 about at least an hour after contrast injection. And then we simply subtract the images in order to get what we call treatment response assessment maps. Lawrence, I apologize. Would it be possible to give me like a 5-minute notice? Please, anyone? I just don't have the timing. Okay, so we subtract the T1 weighted images one from the other, and in order to get what we call treatment response assessment maps, those are the trams. And in the trams you can see two populations. Blue is a negative signal and red is a positive signal, and I'll explain. So if you look at the blood vessels in the brain, immediately after contrast injection the signal is maximal, and then it decays with time, and therefore if we'll do 1 hour minus 5 minutes, we'll get a negative signal showing blue in the maps. On the other hand, if you look at the cyst over here, gadolinium will accumulate after 1 hour, and therefore when we do 1 hour minus 5 minutes, we'll get a positive signal showing red in the trams. And what we found by comparing the pre-surgical trams with histology in over 50 patients was that blue regions in the tram represent morphologically active tumor, while red regions represent everything else, including treatment effects. And we believe the rationale stems from the morphology of the blood vessels in these regions. So if you look at the blue/tumor regions in histology, you will see different types and shapes of tumor vasculature. But what is characteristic of these vessels is that they are viable, and therefore they're able to efficiently clear the gadolinium 1 hour after contrast injection. If you looked at regions of treatment effects, the blood vessels are at different stages of vessel necrosis, and therefore gadolinium keeps leaking and accumulating in the extracellular region. So the whole novelty of the trams is that we wait at least 1 hour, and by this time, tumor will clear the gadolinium, treatment effects will keep accumulating the gadolinium, and therefore we get near complete separation between these two pathologies. I'm going to just skip this part. And so as I said before, we compared the pre-surgical maps to histology in 54 resected patients. Actually today we are closer to 100 patients. And we found a specificity of 93% and 100% sensitivity to morphologically active tumor. And we also looked in a subgroup of patients that were resected en bloc, where we could assess the tumor load in histology. And we compared the tumor load with the blue load in the pre-surgical maps, and you can see this very nice correlation. So the trams have been in clinical use in Israel since 2012, and since 2014 we started scanning patients with standard medical coverage. We have a quota of 40 patients per month that are scanned with the trams for decision making. In addition to that, we have recruited over 400 patients to our clinical ongoing studies in Israel, and probably another 130 patients in our international studies. So I would like to give you a few examples of how we use the trams in the standard clinical scenario. This is an example of a GBM patient that was recruited to our study 3 weeks after the Stupp protocol with this small enhancing lesion. She was followed every 2 months, and you can see that 4 months after the Stupp protocol, the enhancing lesion started to grow. peaking in values 6 months post-Stupp and then shrinking back. What the trance showed is that there was a small, mostly blue lesion, and at 4 months when the enhancing lesion started to grow, you can see that it's mostly the red component, the treatment effect component, that was contributing to this increased enhancement. And therefore, assuming pseudoprogression, the patient continued adjuvant temozolomide. And this continued also at 6 months, where the volume peaked, as I said before. At this point, you can see that also the tumor component started to grow, but still the treatment effect component, the red component, grew much faster. And therefore, again, assuming pseudoprogression, the patient continued adjuvant temozolomide, and you can see the nice shrinkage later showing classical pseudoprogression. This is the opposite example, progression of a patient that was 49 years old GBM when he was recruited to the study 1 week after the Stupp protocol with significant clinical deterioration, showing this huge lesion growing into the previous surgery site. When we scanned him by the trance, we found 40% blue, 60% red. And since we were not sure which of the two components was the one rapidly growing and causing this deterioration, we scanned the patient again 2.5 weeks later. Standard MRI, including flare, diffusion, and perfusion, showed no difference whatsoever. But in the trance, you can see that the blue, the tumor component, grew by nearly a factor of 2. And therefore, a couple of days later, the patient was resected. And the neurosurgeon took for us a piece unblocked, showing the typical morphology of this lesion, a central red region surrounded by a thick blue rim, correlated nicely to this central necrosis surrounded by a thick rim of morphologically active tumor. So as we do routinely in Sheba, the patient was scanned about 4 weeks post-resection. This is his second resection. And you can see in the trance that the resection cavity, or the enhancing region surrounding the surgery site, is mostly red, suggesting the surgery was successful. But the patient was not started on adjuvant temozolomide because he was hospitalized with meningitis. So we scanned him again 3.5 months after the second surgery when he recovered from the meningitis. And you can see that again, most of the enhancing region surrounding the surgery site is red, although you can see a couple of blue masses here and here. He was started on adjuvant temozolomide. 2 months later, he's feeling fine, no symptoms. He's coming for a routine follow-up, but this time we see this thick blue rim surrounding the surgery site, suggesting progression, and therefore, despite no clinical symptoms, he was switched to Avastin, and he lived for another 6 months or so after this MRI. We do the same thing with brain metastasis. This is an example of a patient with a breast metastasis. She underwent a SRS. The lesion completely disappeared. 2 months later, you can hardly see it, and then 5 months post SRS, there is either recurrence or radiation necrosis, so the patient was recruited to our study. And at this time, 5 months post SRS, we only saw a couple of blue pixels. She's not symptomatic, so we followed her for another 3 months. And by this time, the lesion did grow, showing significant blue regions in the trance, and therefore she was resected. And as usual, we asked the neurosurgeon, please take for us a biopsy from the red region, showing radiation necrosis, and from the from the blue region, showing morphologically active tumor. Here, the patient was scanned 3 weeks post-surgery, and you can see that, as usual, there's an enhancing region surrounding the surgery site. It showed a thin blue rim. Now, as you may understand by now, the blood vessels in the brain also show blue. So at the moment, we have no way to differentiate blood vessels from tumor in the trance. And therefore, when we see a very thin blue rim like this surrounding the surgery site, we don't know if this is wound healing angiogenesis or is this residual tumor. And then again, we followed the patient, and 2.5 months later, it did become massive. So the patient was re-radiated to the surgery site with a very nice response. After 3 weeks, blue turns into red and nearly disappeared. We followed her for another couple of years. She was clean. Sometimes we don't need follow-up in order to make a decision. It's very clear, like in this case. He was 30 years old, yield cell carcinoma. He was clean systemically. He had 3 brain lesions. He arrived to us on a Wednesday night with significant headaches, saying that he already underwent whole brain RT and SRS and was not responding, and he was scheduled the following week to undergo another whole brain RT session. So we scanned the patient, and you can see that all 3 lesions look mostly red. There's a thin blue rim, but it's like 90% at least red. Therefore, from our point of view, this is radiation necrosis. We sent the images to the hospital where he was supposed to do whole brain RT, and they canceled the radiation therapy, and instead they took out the largest lesion causing the symptoms. And you can see the nice correlation again between this red lesion with a thin blue rim and this radiation necrosis lesion and a thin rim of morphologically active tumor. The trams have also additional applications, and what's nice about them is that they're not sensitive to susceptibility artifacts like perfusion or diffusion, etc. We are using robust T1 weighted images, so we are not sensitive to bleeding, for example. So the trams can be used in order to depict active tumor within bleeding. You know, we have a lot of bleeding in GBM and melanoma and so on. These are 3 examples of melanoma patients post-SRS with the bleeding, with a question, is there active tumor within the bleeding? So the first 2 patients, there was no blue region in the trams. Bleeding sometimes look light blue, but it doesn't show dark blue like tumor. So we just waited a few months until it was absorbed. But you can see that in this lesion within the bleeding, there's a dark blue area. It looks like a spherical area with this hook-shaped extension taken out on block, and you can see an histology, a round tumor with a hook-shaped extension. Trams do not work with non-enhancing tumor, at least not yet. So we cannot help patients with low-grade gliomas. But when there is new enhancement within a low-grade tumor with a question of malignant transformation versus treatment effects, that in those cases we can help. And this is an example of a low-grade tumor with new enhancement, and you can see that there's some treatment effects, but there's definitely a significant component which shows active tumor, so this patient was treated as a high-grade tumor. Regarding children, we never did a study on children, and we expect that the delays there may be different. The delays that we have determined to be good for diagnosis of adults, as you remember, is 5 minutes. The first time point at 5 minutes post-contrast injection, and the other one at least 1 hour later, between 1 and 2 hours. So for children, it probably would be different, and anesthesia may also affect this timing. We have never studied it. Still, our pediatric neuro-oncologists have no better information, so they are using the trams. We cannot scan these patients. It's done with standard medical coverage, and decisions are made. So far, it's fine, but as I'm saying, we have not done a study on that. We would love to collaborate if anyone is interested in that. So this is just an example of an 8-year-old. We have quite a few children followed by the trams. Our experience now from we started scanning patients with the trams at 2010, so we have really calculated many thousands of trams, and our experience is that every enhancing brain tumor, whether even if it's malignant or benign, if it's enhancing, it will show blue, and treatment effects always show red. Also, when we look at other types of brain pathologies, such as AVM, etc., but we have really good database of histological validation only on brain tumors, but various kinds of brain tumors, and we have patients sent with all type of brain tumors. We have been asked, when is the best time post-surgery to look for residual tumor, post-surgery, among other things, in order to plan maybe SRS or fractional radiation to the surgery site. And we don't really have a definite answer on that either. In our hospital, I think in most hospitals in Israel, Patients are scanned between 4 and 6 weeks after the surgery. So this is the time that we use. And at least in our hospital, some of the doctors use the residual tumor they see in the trance to give a boost to specific regions of the surgery site. But I don't think they would trust that if the trance don't show blue, there still could be small cells that we don't see because we are really sensitive to the vasculature of the tumor. So we need some kind of a macroscopic tumor in order to see it. But we had a few studies where we scanned patient early on. This is an immunotherapy study done with a group at Ichilov, and there we have some very early post-surgery images, so I just wanted to share them with you. This is a patient that was scanned 1 day post-surgery. These are 2 slices in the same lesion, and then as a function of time thereafter. So in this case, you can see that there was kind of residual tumor that maybe you can see all the way from the beginning, and it grew with time to be tumor. But in this case, on the other hand, I don't think we saw anything in the first day. We saw like these 2 blue dots a month later, which is again the standard time, and then that grew into being tumor. This is another patient on the same study. And here, on the other hand, we didn't see anything suspicious in this part that crossed the midline. It did become blue after some time, and then it disappeared again. So I'm not sure, but this part of residual tumor in the surgery site, this one did grow with time. So it's really hard to say. And there was even a new lesion here that, of course, we could not predict before. That was 2.5 months after the surgery, and it grew into a full-blown tumor. It was resected, but what we could see very nicely, or not nicely, but very clearly, 4 weeks post-surgery is the spread of the tumor within the surgery site, and then it grew into a full-blown tumor. So maybe just one more example on this of the post-surgery changes. This is a patient that was resected after seeing this very blue thick rim surrounding red region of necrosis. You can see again that it looks nicely unblocked, the central necrosis surrounded by a thick blue active tumor. And then 4 weeks post-surgery, there's this very thin blue rim, which again, we can't say definitely that this is tumor, but the patient was treated with SRS, and she had this really aggressive recurrence at 3 months. She was resected again. This time the neurosurgeon knew he will not be able to take everything out, so there is some residual tumor here on the midline. And she got, again, SRS, and again it grew, and actually she died just a couple of weeks after this MRI. But we also have some happy stories, the happy endings. So these are patients that did respond nicely to SRS, and so you can see that this enhancing lesion of breast cancer metastases looks all nice and red. There is a blood vessel going through, but it is obviously a blood vessel, and then it shrank, and there was no tumor here. And this is another one that came to see us post-surgery with this very little enhancing surrounding the surgery site. Is there residual tumor or not? It looked all red, and it disappeared. We have definitely a problem with the ring enhancement after SRS. So we have patients coming to us with this picture of a thin blue rim surrounding a necrotic region, usually a few months after SRS. Now the question is this blue thin rim, is it going to grow into a tumor or is it going to disappear? And the answer is that we don't know. In such cases, we always recommend to scan the patient again, maybe not wait 3 months like we usually do with these patients, do it after a few weeks and look at the trend. So you can see these are 2 patients that are post-SRS. They have very similar, this kind of a thin blue rim surrounding the red region. This one disappeared and this one progressed. So we have to be careful on these type of patients. And there's one more thing that we realized quite recently, and we went back to our database to verify it. Remember that I told you that we have 93% specificity, meaning that we are wrong in 7% of the time, more or less. And we are mainly wrong with false positive trance. So we don't really miss tumors. This is our understanding so far, but sometimes we have false positive. And the only explanation we could find until now for false positive is vascular malformations or radiation-induced vascular malformations. And we went back to our database and we found about 6 such cases. Most of them are brain metastasis, but this case I think was, this case is a GBM patient. So this was a recurrent GBM patient treated by immunotherapy, responded really well. And then about 6 months later, he grew this lesion which looked blue in the trance. So there was like a 3 millimeter blue mass surrounded by a thin blue rim. It looked black and gradient echo. At the time, our protocol had gradient echo in it. But you know, black and gradient echo could be many things, including hemorrhages, which we see often in these patients. So, but the patient was symptomatic, he was resected, and histology came back, no tumor. And when we looked at the specimens, we found these radiation-induced malformations, which are very vascular entities, and at the moment we have no way to differentiate those from tumors. So we have seen this now also with several brain metastasis patients, more than in GBM. But our understanding is that it should be very rare, at least from the literature. It should be very rare, and we found throughout all the years those 5 or 6 cases, but one has to be aware of it. So our recommendation at the moment is use some kind of susceptibility-weighted imaging in your protocol. Also, it may help, although in most cases, you know, it looks black and we think, you know, maybe hemorrhages or it is hemorrhages. We don't always know. And of course, these patients always have the surgical screw near or whatever that is a problem with susceptibility-weighted imaging. This is just an interesting case, also very rare. A patient that was treated by Yigal Shushan from Jerusalem. She was 14 years old when she was admitted to the hospital unconscious with a bleeding AVM in the ventricles, and he treated her with SRS. And 6 years later, about I think a year ago it was, he calls me and he says, you know, look at these trams, they're blue. What do you think? Is it an AVM that grew back from the original site all the way up, or is this a radiation-induced glioma? And you know, we couldn't really help much. Usually, we have scanned like I think 12 or 15 AVM patients, and AVM, when it's untreated, does look black in the trans. Usually it has kind of a vascular structure, so we were trying to play with the contrast here and see if we see a vascular structure, but we didn't. It looked kind of massive, but you know, we didn't really have the courage to say we don't think it's a vascular structure. He was really afraid to biopsy it if it was an AVM, and she will bleed, but in the end he did biopsy it, and it was GBM. This is how it looked post-resection. At the time she was fine, I didn't follow. Could you just tell me how much more time I have? I apologize.
How much? No, it's very interesting, so don't worry about it.
Okay, I'll go just a little bit more. Thank you. All our patients are scanned by perfusion-weighted MRI. Also, it's the standard protocol in our hospital. So most of them are scanned with DSC, and for one of the studies, we also scanned a few 40 or 50 patients with DC. And when we published the final histological validation in the 54 patients, what I told you, it was in neuro-oncology, and of course our reviewers are always perfusion people. It took us 10 submissions to 10 different patients, to 10 different journals to publish our first paper on the trans. We were really swimming against the flow. So they asked that we do a numerical comparison with DSC. So we had the calculated RCBV, just calculated on the GE console standard software, and we did some ROI analysis. We had 46 patients that had both the trams and the RCBV and histology. So they asked us to do this ROI analysis. We defined enhancing region on the T1 weighted MRI, copied it to the trams and to the RCBV maps, And then in order to decide what is a high RCBV, we used what we took from the literature, 1.8 of normalization to the contralateral. And you can see that these are the pixels that were determined to be tumor, passing the threshold of normalized 1 or 1.8 value. And what we found in those 46 patients is that all 46 patients had a significant number of pixels that had RCBV higher than 1.8. So we got 98% specificity and 100% sensitivity to tumor using RCBV. And we said this does not really agree with what we see in the clinic. It does not make sense, but they forced us to do this type of analysis. So in order to explain why it happened, we did the following analysis. We took the same region of interest of the tumor and we copied it to the contralateral side. You can see it here. And we counted now in the contralateral side how many patients will show tumor or will show RCBV greater than 1.8. And you can see that in all cases we got it. So in general, at least in this type of analysis that we done on those type of RCBV maps, you can see that any place you will put a region of interest of the brain, you will find high RCBV because of the normal vascular structures in the brain and the low resolution of these images. So when we did this analysis, we showed that we get tumor in the contralateral hemisphere, exactly the same tumor volumes and with exactly the same precision when we did it in RCBV. Of course, we repeated this analysis also for the trance, and there we could show that in the real tumor hemisphere, we got tumors with an average volume of 11 milliliter, and in the contralateral, where we happened to capture a blood vessel, it was 10 times smaller. And of course, in the trance, you wouldn't think that there is a tumor when you see a blood vessel in the contralateral region. So we thought, okay, this is not the right type of analysis, at least for us to do with RCBV, and therefore we added for the reviewer also a clinical assessment of what is high RCBV. We asked our neuro radiologists to go over the RCBV maps and give them a score. Is this high or moderate or low RCBV according to their understanding? And when we did that and we looked at the same 46 patients with the histology, we found that the specificity of RCBV to tumor in these 46 patients was 96%, and the sensitivity was 50%. Now that made more sense, although it still looked high to what we are used in the clinic. And therefore, what we did in the same 46 patients, we compared the RCBV to blue regions in the tumor. And we got the same result as we got as comparing to histology. We got 100% specificity and 48% sensitivity. So it looks like we can maybe use the trance as gold standard instead of histology, and then we can expand easily to a much larger cohort of patients. So now we compared RCBV to blue regions in the trance in a larger cohort of 207 patients, which includes these 46 patients. And then we got RCBV has 100% specificity and 23% sensitivity to blue regions of the trance. And this can be explained by the fact that the cohort of patients that were resected have larger, more massive, and more vascular tumors, probably. For example, the 207 patients in the larger cohort included 30 patients with small brain mets, which never show any sign on RCBV. So this looked a little bit more like what we are used to from the clinic, about 25% sensitivity of RCBV to tumor. And then we did the same analysis using the DCE data. So we had 42 patients that we scanned with DCE. We did not have histology for these patients, but what the analysis showed when we compared the K-trans values to blue in the tram was we set the specificity to be 90%. It has to be high in order to have in order to be a valuable tool, and the sensitivity was then about the same. So we have several ongoing international studies. in the United States, Europe, and Russia. We are also happy. One of our specialties of my research group is convection-enhanced drug delivery, where you implant a catheter into the brain tumor and you infuse chemotherapy directly into the brain. So they're one of the companies that we used to work with in vivo several years ago, and that is now doing a multi-center clinical study in the United States with about 10 or 11 centers, and we are monitoring now the convection with the trance. It's really, really nice. Two of our collaborators in Milano and in MD Anderson were using the trance for immunotherapy studies, and they're just now summarizing the data. They just finished recruital, so I really would like to, I hope to see that they're going to publish with the trance soon their results. That would be really nice. The last thing I want to say is I just told you it was really hard to publish the first paper on the trance, and that was in 2012. So at the end of last year, there was a first publication of another group that did the same thing with brain metastasis. This is a German group that showed that they can use not 5 minutes in an hour, but 15 minutes and 55 minutes, and they do a subtraction, and they also show that they get a nice differentiation between radiation necrosis and malignancy in a more homogeneous group of patients, which are all brain mets after SRS. So this is really nice for us. I heard there's another such study that hopefully will be published soon. Of course, we work with animals all the time, mice, rats, and these are dogs with spontaneous glioma. And that's it. So I really want to just summarize and say the trance are able to efficiently differentiate tumor from treatment effects with a high resolution. It's very easy to interpret. Blue is tumor, red is treatment effects. It's robust because we're using standard 3D-T1, whatever you use in your hospital. It's model independent. We just subtract two images. We don't make any assumptions. And it can be used for planning high precision treatments such as SRS or implanting a catheter or biopsying blue regions, etc. Thank you very much.